CFAR conference this Friday. So upcoming dates. So next week we have a talk about our early intervention services that will include Carmeletta Abel, Kay Park, and Joyce. And then we'll see how long that discussion takes, and then probably have a case at the back end of that. And then the following week, which is the Friday before Memorial Day, so we'll have a case discussion for those who are available to come. Please do come. And then I'll be here. And then after that, we have an ID town hall meeting coming up as well. So today, to the main event, we are very fortunate to have someone who I think all of us have spoken to our patients about many times. And all of our patients know immediately who we're talking about, whether or not they know her by name or just that really kind person. So Jean Keller has been caring for people living with HIV, and particularly women, in the Johns Hopkins Women's HIV program for now more than 30 years, and is the co-director of that program. She provides reproductive health care to women in our clinic, as well as is just someone who I hesitate whenever anyone goes anywhere else, because I know when they come here, they'll be met with acceptance and compassion, and they'll feel comfortable and able to really get the care that they need. So she's going to give us an update today on GYN and women's healthcare. And thank you so much, Jean, for joining us.
Oh, of course. So let me try the screen sharing and see what happens. We want this one. And did it happen?
It looks perfect.
Oh, great. Terrific. Okay. So thank you for that kind introduction. And I have to say, I don't find it hard to take care of our patients. I really love what I do, and I love the clinic. Been doing it, since 1988. And I actually came in, a lot of people don't know this, I actually started in the infectious disease department before I met Dr. Anderson. And after 3 years, we really worked towards making this a comprehensive program. So having said that, there we go. Okay, so my objectives today are just to really give you an overview of what the Johns Hopkins HIV Women's Program has available, and just so you know what services we have and what we do. I'm going to probably spend most of the time talking about lower genital tract screening in women living with HIV, because I think that's a huge proportion of what we do and what you all are concerned about, and you know by seeing all those abnormal pap smears that we deal with. I'll talk a little bit about what the routine GYN exam is in the Bartlett Clinic and some of the common problems. And the other topic I really want to address today, my keyboard by accident, is preconception counseling. It's really important for a number of reasons. And I'm going to talk about this a little bit later, but in Maryland, it was sort of a bad year for us. There were 7 infants diagnosed with HIV in 2022 after having 0 in 2021. So this has really come to the forefront, and preconception counseling, I think, is an important part of preventing that. And then, of course, pregnancy and HIV, because that's a big part of what we do and what you all refer to us for. So the overall view, it's really like 3 arms that I think about it. So it's the HALO program, which you're all pretty familiar with. It doesn't stand for anything. It was named by the patients. And it's really perinatal care with antiretroviral expertise. And we are very fortunate at Hopkins because we have maternal fetal medicine doctors who are not only experts in antiretroviral therapy, but also other high-risk pregnancy issues. And of course, we have you all to consult with when we get out of our comfort zone with antiretrovirals. I think what really makes our program special and unique is that we are able, just like you do in the Bartlett Clinic, we are really able to have wraparound psychosocial services for our patients, and then finally linkage to care postpartum. I'm going to talk about that a little bit more on the next slide. You're all familiar with our comprehensive reproductive health services in Bartlett, but I also wanted to know that for patients who don't want to be seen in Bartlett for whatever reason, for GYN, we can offer the same thing at Green Spring Station and Jayhawk, and both Anna Powell and Dr. Coleman see patients at those sites. And even if they don't see Dr. Coleman or Dr. Powell, our providers are very comfortable with HIV, and they know to reach out to us reach out to us. And then we do provide some services in Baltimore County and Anne Arundel County. That's me. I go to those counties to provide at the health departments reproductive health care, and we're hoping to expand that as well. And what you might not be familiar about is our SOAR program, and that's a collaborative we have with Baltimore City Health Department, and it's an outreach program. I'll talk about that a little bit more and within the next couple of slides. So I'm really proud of our perinatal care program. It used to be, when it was first initiated back in 1988 by Dr. Anderson, it was a midwifery model, and it's really grown from there. We receive funding from HRSA through Ryan White Part C, direct funding. So we really are able to provide comprehensive services. And not only that, but we can take care of women who may be uninsured. And that's usually undocumented immigrants. Most women in Maryland receive medical assistance when they're pregnant. So really, we don't have to turn anybody away. So it includes perinatal care, including labor, delivery, postpartum care. We have HIV primary care during pregnancy. Our providers, our perinatal care providers are Anna Powell, Jean Sheffield, who is the Director of Maternal Fetal Medicine at Hopkins. Some of you might know from her ID work and pregnancy. Cynthia Organi and Lorraine Milio. And they each have other expertises in high-risk pregnancy, including substance use disorders. So again, antiviral expertise, we don't have to send patients anywhere else during pregnancy. We talked about this a couple of weeks ago, our screening for breast or chest feeding. And we've been doing this now for a few years, and it's really a harm reduction model. Patients who want to breastfeed are go to a consult visit with our team plus the perinatologist and pediatrics. So we really work together to make sure that it's appropriate for that patient and it's safe, and they know that they can call us and tell us what's going on. We have a wonderful new medical case management manager. You might not know her yet, but I'm going to introduce her. Her name is Jennifer Lenore, and she's our newest member, and she not only has a master's in social work, but she's certified in perinatal mental health, and she's a doula. So we really hit the jackpot when we brought her on board. We have a dedicated nurse, Allison Livingston, and I think most of you know she has years of experience in HIV, and I've probably forgotten more about HIV than she knows. And she is a great contact point, particularly for pregnancy. She will get patients in immediately. Non-medical case management, I think most of you know Rose Ramroop. You see her around the clinic. She's been with us for over 25 years. She is that important link from the provider to the patient, and we couldn't do this without her. We have access to research, and we have fourth trimestral linkage. We call that the fourth trimester because it really is important, because we found that we were losing many women after they delivered because they're taking care of their babies. So we really want to make sure that both mother and infant are linked to care. So, all right, here we go. So, hang on. There we go. County Reproductive Health Service, I talked about this a little bit, but we also consult with the county. We get a lot of referrals in pregnancy from the counties other than Anne Arundel and Baltimore County. And years ago, before Dr. Anderson retired and left us, she used to provide grand rounds throughout the state to update community physicians and OBs on HIV perinatal guidelines. And we're hoping to restart that again and put Anna Powell on the road. And then we can also consult with OBs throughout the state if they're taking care of women with HIV. So just quickly about the SOAR initiative. This is a great initiative. This is a partnership with Baltimore City Health Department. It's a Ryan White initiative. They partnered with the Maryland prison system, and we are one of several agencies that actually goes into the prison, or we did before COVID, but we link patients who are ready to be re-enter the community. Prisoners who are ready to re-enter the community are linked with a outreach worker who then helps them access primary care and other services that they need to function in the community, and that make sure that they continue on their antiretrovirals. Both Latasha Davis and Dustin Bradley are senior outreach specialists with us who do a phenomenal job. Dustin is the primary person in the SOAR program, and Latasha does it part-time and also helps us in the clinic as well. So you'll see her name on a lot of communications because she's the one that makes things happen when you all need something. Okay. So what is the routine GYN exam? And I put that in quotes because if I was talking to medical students right now, this would be a totally different slide. Because the primary healthcare is so good in the Bartlett Clinic, we really get to focus on reproductive health care. And I say this because, when I first started practicing and I would doing GYN care, a lot of particularly young women only see their gynecologist. So really the routine GYN exam encompassed more than just reproductive health care. But because of the great work you all do, I can just review their history, review what's going on, and really get to what we need to talk about. And we do see a lot of recurring themes in our clinic. And first and foremost is cervical dysplasia. That's a result of persistent recurrent HPV infection. We see STIs and vaginitis. The most common STI we see is actually trichomonas because we have a little bit of an older population. So I want to put a plug in for making sure when you screen to make sure you include trichomonas in your screen. A lot of menstrual disorders and abnormal bleeding, some pelvic plane issues, which you can see in any GYN clinic. We deal with contraception, preconception counseling, and of course with our aging population, menopause. And I'll talk about those a little bit later on in the talk. But I really want to concentrate today on lower genital tract screening in women living with HIV and the prevention. So as you all probably know, or I can remind you, actually the pap smear was developed in 1943 by Dr. Papanicolaou, which is why we say pap and not Papanicolaou. It's kind of a tongue twister. He introduced that screening test for abnormal cells of the cervix, and it was a game changer in terms of saving lives for women who would develop cervical cancer. And I can tell you that cervical cancer is still the 4th leading cause of death among women worldwide. So having this screening test available has really saved millions and millions of lives. Although we still we have great screening, there are still about 4,000 women every year who are diagnosed with cervical cancer in this country. And if you had to guess who those people were, those are the women who have, for one reason or another, stopped having GYN care, particularly after they stop having babies, and then they come back when they have a problem, and then because screening wasn't done, the cancer wasn't picked up. Women hate having pap smears. I love this cartoon. I can reassure you that when I do a first exam on women, I don't show them the speculum while they're in the stirrups and try to talk to them beforehand. But this is a reaction I'm sure that we all remember, as at least the women in the audience, when we first had our exam. It's not a fun experience. So we try to make it as easy as possible. So, when we talk about failure to diagnose cervical cancer, there's lots of places where people fall through the cracks. And I want to point out, I think this clinic is very good at providing, referring women to us, but this is the problem. They make the appointment and they may not come in. So, we try to be diligent about making sure that we get them in, and we're very flexible. If they, miss an appointment, they can schedule another appointment, and I don't care if it takes 6 appointments to get a woman in. We'll make sure that they get their screening. It really, in my mind, it's really important to make the patient feel comfortable during the exam. So it's bad enough having a GYN exam, but you want to make sure that there's an environment that's open and friendly so that they will come back to see us. The other places they fall through the cracks is that if they have an abnormal the evaluation is not done, or for some reason they don't get to their appointment. And this all can lead to a diagnosis of cervical cancer. So I think you are all, I want to talk, I'd be remiss not to talk about the vaccine. It's now a 9-valent HPV vaccine. I know I'm not supposed to say Gardasil, but that's what we're all familiar with. And it includes the most important types, 6-11, which is warts, 16, 18, 31, 45, 52, and 58. And the guidelines, as our adolescent colleagues know, really want the vaccine given before sexual activity starts. So if they get the vaccine between 9 and 14, it's a 2-dose regimen. If they're over 15, the recommendation is to do a 3-dose regimen at 1 month, 2 months, and then 6 months after the initial dose. So when we talk about adults, 26 to 45, it's really not recommended for everybody over 26. And particularly with women, with people with HIV, rather not just women, but people with HIV, the current data doesn't support vaccination as no benefit has been seen. However, there may be some situations in patients who have minimal HPV PV exposure where it is absolutely appropriate to give the vaccine after 26 years of age. And I just wanted to also shout out that, now that we have, such great antiretroviral therapies, we sometimes don't promote condoms as much as we used to, but condoms actually protect against HPV, as does male circumcision. So I know you're all familiar with the Bethesda Pap smear classification, but just, really briefly, what it's looking at whether this, is the Pap smear normal? Are there reactive changes seen? And most importantly, are there epithelial cell abnormalities? And those are classified as ASCUS, which is atypical squamous cells of undetermined significance. ASC-H, which means they have ASCUS but cannot rule out high grade. Low grade lesions and a high grade lesion. So the low grade is the old CIN1, high grade is the old CIN2 and 3. And of course, whether or not they have squamous cell carcinoma or adenocarcinoma. I also wanted to bring to your attention AGUS, atypical glandular cells of undetermined significance, because this has to be evaluated. It should not be confused with ASCUS. So just to give you a brief reminder from your days as medical students about what exactly is going on in the cervix. The cervix is composed of columnar and squamous cells. So when we're young, our columnar cells are more on the outside. So you can see here, there's this line out here, which is the original squamous cell, the junction. And as we age, the columnar cells are replaced by squamous cells, and it starts to move towards the cervical os. And this is important in terms of getting a pap smear and also when we do colposcopy. So that's why it's really important, particularly in older women, to make sure that we get a pap smear sample from the cervical os. In between the squamous and the columnar cells is called the transformation zone. And this is where, if something's going to go wrong, this is where it's going to go wrong. So as this starts to, again, ascend into the os, we have to make sure that we're picking up that transformation zone when we get a pap test. So this is a review for you. This is your ID doctor, so you know probably as much about HPV or more than I do. But we do find in HIV-infected women higher incidence, and they're more likely to have persistent HPV infection. And persistence is the key word in development of dysplasia. We see higher HPV viral loads in our population, and more likelihood of having multiple HPV subtypes, and a greater prevalence of those oncogenic subtypes. We know that HPV prevalence and persistence and viral loads really increase with decreasing CD4 count, increasing HIV RNA levels. And fortunately, most of the people we take care of are doing quite well on the antiretrovirals. and also that the oncogenic subtypes might be more common with lower CD4 counts and higher viral loads. So again, this is sort of just an idea of what the most common HPV types related to cervical cancer are. And HPV 16 really is the bulk of virus that causes cervical dysplasia, followed by 16, and then this sort of smattering of others. So I put this slide up here just to assure you that when we test at Hopkins for HPV type, it also includes the other types, and those types are, listed down on the bottom. And it really covers the whole oncogenic spectrum in terms of development of dysplasia. Cervical carcinogenesis, it's really once that transformation zone gets infected with a high-risk HPV type, and there's viral persistence of HPV, this really leads, the progression of persistent infection really can lead to cervical precancer. And that's why HPV testing has become such an important part of our screening process, because we do know that if somebody is negative for high-risk HPV, their risk of cancer is nearly zero. So this has been a game changer, HPV testing, in terms of how we screen for cervical dysplasia. Let's see. So, when do we screen? So the guidelines are different, and these are taken right from the HIV clinical guidelines. Now, let me just say, if you try to look for these, it's really hard to find because they're listed under opportunistic infections HPV. So if you're ever looking for the guidelines for Pap smears, you have to dig a little bit. It doesn't just like pop right out. So it's under opportunistic infections HPV. It kind of makes sense, but I think it gets lost too. So for women less than 30, there's a difference between HIV and infected women and negative women, even in the young ages. So for women who are not HIV infected, Pap smear is not recommended until 21. This is a little bit different for our population. The guidelines say that if you can get it less than 21 or 1 year after the onset of sexual activity. So once that girl becomes active, a Pap smear should occur. And then from 21 to 29 years of age, having a Pap smear every year for 3 years. And if all are consecutively negative, they can go for every 3 years. We don't recommend co-testing with HPV in women younger than 30 just because of the prevalence of HIV in this population. And it's not really clinically helpful and may lead to like unnecessary colposcopies and biopsies. So we wait until they're 30 years of age. And I have to say, every once in a while, I do forget to change that. And I wind up getting an HPV test on a girl that's, less than 30. And then if it's positive, I'm stuck with, now what do I do? So I try not to forget to take that out of my my lab flow when I have a woman younger than 30. So for women over 30, the first two tabs are really, we don't really see this anymore. I think almost everybody is doing co-testing now. However, if you are, if somebody is at an agency where they don't have co-testing, it's 3 consecutive Pap smears every year. And if all are negative, they can go every 3 years. But at Hopkins, we've had co-testing for quite a few years. And it should be done again, obviously at baseline. And then if they have a negative Pap test and a negative HPV test, they can go every 3 years between Pap tests. Doesn't mean that they shouldn't be seen every year, but they can go every 3 years for their Pap test. If the Pap cytology is normal, but it's HPV positive and it's other type, that means anything but 16 and 18, repeated in a year, and if it's still positive, they should be referred for colposcopy. However, if they have a normal Pap smear and it's HPV 16 or 18, you should refer for colposcopy. Currently, unlike women who are HIV negative, by the way, women who are HIV negative, is, most of us know, it's every 5 years, but currently there's no age cutoff for HIV infected women. So For, women in the general population who are 65, have no history of high grade, we could stop pap smears at 65 years of age. That's not true yet in our population. I'm not sure it will ever be true given our prevalence of HPV. So in diet, I want to include lower genital tract neoplasia. Then, so I'll briefly talk about warts and anal and vulvar and vaginal neoplasias as well. So warts are pretty much, the diagnosis is pretty much made by visual inspection, unless, and if it's not typical though, which is very common in our clinic, they really should be biopsied. In terms of vulvar and vaginal lesions, it really is, again, visual inspection, including high HRA and colposcopy. We biopsy pretty readily, anything that looks abnormal. And for anal pap, the current HIV guidelines advocates anal digital exam for screening. And I'm going to talk about that a little bit more later about what we're doing in our clinic, because I don't think the guidelines have quite caught up with some of the literature. So yes, I can't do a GYN talk without showing you gross pictures. Just so the picture on the top is a typical wart. You can see that it's raised, it's fleshy color, it's got that bumpy appearance. So I would feel really comfortable just, treating this as a wart. As opposed to the pictures on the bottom, you can see that the sort of white plaque lesion here. It's flat, it's not raised. There's another lesion here that's hyperpigmented. And this third picture, you can see they kind of look warty, but not typical warty. So all of these when biopsied were VIN3. So always have a high degree of suspicion if you happen to see something that looks like this, or if a patient presents with something with a lesion, please, send them to us as quickly as possible. We'll take a look and make sure that we biopsy if needed. So let's talk about a little bit about anal pap testing. And I'm sure Joyce is on this call because she really has been the pioneer in our clinic about us doing this for women. And I thank her so much for pushing me on this. So, the anal canal and the cervix really share sort of this similar histological and pathological characteristics, and it comes from the embryological development of that lower genital tract. And again, like with cervical, HPV is really needed for the development of SIL in the rectum and the anus. So in this one study that I found, I think it was a study just looking at all the literature, they really found prevalence of anal HPV infection up to 90% in women with HIV. So, this was back in 2016. This really, got us thinking, what are we missing here? And I just want to remind everybody, women does not have to have anal intercourse to have HPV infection in the rectum because of the secretions, just the way we're built, that the secretions can easily infect the anal canal. And that's what gives us probably that high prevalence that we see. So the guidelines vary. When you look at the guidelines, they're all very, very variable. But, when you, I went to a talk recently where Dr. Palevsky was speaking, and he's like the guru of everything anal dysplasia, and just an amazing man. And he really does recommend screening for AIN with anal pap smears for all individuals with HIV. The only caveat is that making sure there is local expertise in the cytologic result, because you're going to get a lot, as we do in our clinic, we get a lot of positives, and you really need to be able to send the patient for interpretation and HRA. So this is his biggest caveat. We are lucky now that we have an amazing clinic at Green Spring. This used to be an issue a couple of years ago, and one of the reasons why we held off doing anal pap smears in women, we just reserved it for those women with evidence of HPV. So I'm really happy that we have that available.
Jean,
again, Sure.
interrupt real quick? There's a couple of questions in the chat, but one from Meredith Harris that I think is really just timely. So should this be done at every age or with 30 and up, or what are
30,
your?
yeah, I would do 30 and over. I think when I was reading his guidelines, it's 30 and older. Yeah.
Perfect,
Good
thank you.
question. Mhm. The only caveat I would say to that, and I'm not sure, we'd have to look that up, is maybe if they're practicing anal intercourse, should we, so I'm not, that's again, something we could talk about. There's a lot of gray areas still in this, but great question, Meredith. Thank you. So again, this is very similar to cervical pap smears. I'm sorry, we're back to cytology. I'm there. So back to cervical pap smear. Sorry, lost my place here. When should you refer for evaluation? So I think we talked about this a little bit earlier. Normal pap, HPV 16 or 18, absolutely. Normal pap with repeat other type of HPV. But after that, if somebody has ascus and negative HPV, again, you can repeat the following year. And then if it's still ascus, refer. But if there's ascus in any HPV, go ahead and refer. And then anybody with a low grade or greater should be referred. And that includes especially ASK-H and atypical glandular cells. So ASK-H means that they can't rule out the high grade. And when I once gave a lecture, and there was a pathologist actually in the audience, and she really helped me understand why this is important. She said that the cells, when you look at ascus, they more closely mimic high grade than they do low grade. So if they're really not sure, that it's called ASK-H, and we really want to rule out that it's not a high grade. And I didn't know that before that, giving that lecture, and I still quote her to this day. And then for anal pap smears, it's ascus or greater, although maybe Joyce can speak to this later. I think we can start doing HPV testing with our anal pap smear. So we may be revisiting this, and maybe Joyce later on can let us know where that stands. So what do we do when we have, we do colposcopy? So again, this is our graphic of the cervix. Of course, it never looks quite that nice. But we really need to view this transformation zone. Okay, so there might be some words you have seen and don't quite understand. So when we say a colposcopy is adequate, that means the colposcopist can see the entire transformation zone. If they can't, so say some of that transformation zone is now in the cervical os, it's called inadequate, and that's the difference between adequate and inadequate. It's really important that if we can't see the entire transformation zone, that we make sure that we're not missing something in the cervical os, and that requires a biopsy called an ECC. So I have some more gross pictures for you because that's what I do. So up on the top is normal. And I used to love showing particularly this one to medical students and ask them if they thought this was normal. And they would always say abnormal. That's just cervical ectopy. So that's just that, those are just those columnar cells just secreting mucus, right? These are Nabothian cysts. They look awful, don't they? And I've had referrals over the years for these. And all this is when the squamous cells cover the columnar cells, the mucus gets trapped and you get a cyst. So even though they look really bad, they're absolutely benign. This is a nice, pretty normal cervix here. This is the original squamous cell junction. Here is the transformation zone, and some of it, and this is the new you can see some of this is, well, maybe you can't see, but it's going partially into the cervical os. So below, when we do colposcopy and we're magnifying, so remember these are magnified, the colposcopist can really wants to biopsy, sometimes people have like lesions everywhere. You want to biopsy what looks the worst. So these are examples of low grade, and this is called mosaicism. And you can kind of see there's this like little pattern here. These are just sort of like little blood vessels just making a pattern. And this is, because this is sort of a fine mosaicism, it's considered a low grade. We can see some, acetyl whitening here as well. And then on the right, and this is also low grade, And on the right, high grade, you can see how this is a little bit more pronounced. That mosaicism is a little bit more pronounced. It's a little bit more worrisome. And indeed, this was a high grade lesion. And in this picture, which I know looks pretty awful, there's what we call punctate lesions. There's little vessels here. So all these little punctate lesions are evidence of dysplasia, usually high grade. So in case you were wondering what we were looking at when we look at this, that's it. We do punch biopsy. Again, we have somebody who's skilled at this, like Dr. Powell and Jean Anderson and Dr. Coleman. They could do one biopsy and know that they have the lesion that they need. So because they're so good at this. Remember I told you about if you don't see the whole transformation zone, these are I call the torture instruments of GYN, right? The punch biopsies, patients hate this, obviously, good reason. But the ECC is particularly bad because this has to go into the cervical os and you have to kind of scrape those cells because if you can't see the transformation zone in the os, you need to have tissue to look at it, make sure it's normal. So this is what we do to torture our patients, right? We don't really want to torture them, but we try to do it as quickly as possible. So what happens? How do we treat then? So remember, colposcopy is diagnostic, right? So what happens when do we decide that this needs to be treated? So we treat HSIL. We do not treat LSIL. We follow it conservatively. Although I have to admit, in our population of let me back up for a second. So low grade can often regress on its own in the general population, which is one of the reasons why it's not treated. In our population, there's a tendency to have persistent low grades. So that usually means that women will often have to come almost every year for colposcopy. We could, for those who are, just sick and tired of it, we can talk to them about treating their low grade, but especially if they're a little bit older. But in women of reproductive age or, who are thinking about having children, you really don't want to mess that cervix because you're removing part of the cervix and it can lead to some incompetence. So again, we treat it ablative and laser vaporization. You might remember, for those of you who are a little older, used to be one of the treatments we do. We don't generally recommend this because you don't get tissue. We don't do this at Johns Hopkins, but it's not wrong to do it if that's all that's available. And the reason we like excisional procedures is because we want tissue. We want to be able to say that the margins are clear, and also that, particularly in HIV, we often have larger areas of the cervix that are involved. So we really want that tissue. We want to make sure that we got the whole lesion. We want to make sure that the border around the lesion is clear and that we didn't miss any of it. We do excisional treatment for VAIN is vaginal. VIN is vulvar intraepithelial neoplasia. So we do excisional treatment for that. But any cervical, vulvar, or vaginal cancer really needs to be managed by GYN oncology, of which we have a great team here at Hopkins, and they've taken great care of our patients in the past. So I just want to show you because I just think this is so cool. So this is a loop procedure. So this is an electrosurgical excision procedure. So I don't know what, maybe they made this silver because we want you to see it, but it should not be metal because it's, electricity. But this, if you've ever seen those cheese graters that just look like a wire, that's essentially what it looks like. And it just, it not only cuts the tissue, but it also, causes hemostasis. So it's a really quick procedure that can be done in the outpatient setting. And that's what a LEAP is. So I'm going to move over to talk about preconception care. Am I doing okay on time? Oh, okay, good. So I don't think it's a surprise to anybody in this group that there are high rates of unintended pregnancy in the United States, with 45% of pregnancies being unintended. Among our population, we also have high rates of HIV serodiscordance among partners. So one partner positive, one partner negative. In addition, we now have advances in HIV care and prevention of perinatal transmission, so that when we know a woman is HIV infected and she's on antiretroviral therapy and she maintains undetectable viral load, it is essentially those rates of transmission to the baby is less than 1%. I talked a little bit earlier about the 7 cases that we found that were found in the state last year, and it really lots of red flags went off. There is a perinatal HIV task force, which I'm on, as well as Dr. Powell and some of the other colleagues. I'm really trying to look at this and try to figure out what we're missing, because a lot of this is the high hanging fruit, like what's happened, where are the holes in the system. And I can, I have my opinions on that. And if anyone wants to talk offline about it, I'm happy to talk about it. But we really need to try to fix that, because 7, that's just unacceptable, particularly when the year before it was only 0. So having, and in our age of ending the HIV epidemic, right? So having said that, we also want to do preconception counseling because we want to promote healthier behaviors. If a woman just says she's thinking about getting pregnant and not using contraception, she goes on a prenatal vitamin, make sure she has sufficient folic acid. So really, my goal is that fertility intention should occur early in the course of HIV and ongoing. We really want to help our patients make informed decisions about contraception and pregnancy. And I just, when a patient says to me, well, if it happens, it happens. Oh boy, do they get a lecture talking about why it's important not to really plan pregnancies for a number of reasons, including, the health of themselves and their babies. So patients who have said that to me know they get the lecture after that. So what can the primary care provider do? So I'm actually going to try to put together a little template for you all to use, and for us as well, just as a screening, so that we don't forget about doing this. So, simply, are your patients male and female, are they sexually active, and they just desire starting a family or continuing a family or conceiving, yes or no? And if it's yes, are they thinking about it in the abstract, like not really this year, but maybe in the future? Great. That's great. Go ahead and then make sure they're on, good contraception, and refer them if need be to us for that. But if they say yes within the year, really, really promote offering this preconception counseling that we have in our program, both for them and their partners. We advocate bringing the partner in, whether it's the man or the woman that's HIV positive, so we talk to them as a couple. We do get some people referred who are, women who are going to be artificially inseminated. So that's a different conversation. But we really will see anybody who's interested in starting, having a family or conceiving. And it's a long visit. So and I'll tell you how to do this at the end, but to really schedule that through our office, because it's well over an hour visit. And we really need the time to talk about all the things we need to talk about. So, revisit this annually, particularly if they're sexually active and not using contraception. If they, are they happy with their current contraceptive method, male and female, or couples? Please refer them to us as well. And for the menstruating partner, just last menstrual period, was it normal? Was it abnormal? If it's abnormal, refer to us. If they're using contraception, yes or no, interested in contraception, or please, again, we're happy to see them. If you're not comfortable starting them on contraception, or they want an IUD or some other method, please, let us see them and help them with that decision making. So again, this is just a little bit more about preconception counseling, but I wanted what I wanted to talk about is we can also use PrEP. So another reason for preconception counseling is, in couples that are trying to conceive, the use of PrEP is also an option. So I'm going to make you guys now think a little bit. So Eileen, I can't see who's in the chat. So, or if anybody just wants to talk up and speak, please do. So this is case 1 is a 33-year-old woman. She is HIV negative. She presented to an OB/GYN clinic with her husband for preconception counseling. They wanted to have a biological child together. Her husband was living with HIV. He was taking antiretroviral therapy and had an undetectable viral load for several years. She has never been pregnant and had never tried to get pregnant. There's negative intimate partner violence in the screening. Would you offer her PrEP?
So maybe people can just either pop in the chat or raise their
Yeah,
hand.
you can read them out to me. What do you all think about that?
And I'll just talk while people are getting their typing fingers or
Yeah.
thumbs. So I think I would definitely discuss it with her, depending on what they've been doing previously. If they've
Right.
had a partnership that was 100% condom based because of anxiety about the potential for transmission, even in an undetectable equals untransmittable world, then I would definitely offer it.
I think you nailed it, Eileen. Yeah. So, and the other thing is, if people really push for it, there may be a reason. So, if they really want it, yes. Now, theoretically, do they need it? Will it add anything? No. And we do say that. So, adding PrEP, if you really are monogamous, if you're using condoms once you conceive, there really is no added benefit. However, if they really, for whatever reason, want PrEP, or those, we're not sure, or don't want to use condoms, yes, you can offer it to them. So the second, did anybody say anything differently in the chat?
There's someone else, Dustin Bradley also thought they would discuss PrEP as certainly a possible option.
Yes, exactly. Yeah. So this case is a 28-year-old woman who presented for prenatal care, 24 weeks of gestation. This was her second pregnancy. Her male partner was not present. She did not have any chronic medical illnesses. However, although she tested negative for HIV, she was positive for syphilis at the initial prenatal visit. Her male partner had an unknown HIV status, and she reported that he can be physically abusive at times and abuses alcohol. I mean, I think we would all agree on this one, but if anybody wants to answer before I do, please go ahead.
I think I'd do an HIV viral load at this visit, just because if she's 24 weeks pregnant and having potential ongoing exposure, but then definitely.
Yes, absolutely. Yeah. And that's a good point. I forgot about that point, but yes, I would too. But I think absolutely this is somebody who would benefit from PrEP. I think there's lots of red flags here: syphilis, her male partner with unknown status, and the physical abuse and his alcohol abuse. So all of those things really point to that she would benefit from using PrEP during pregnancy.
Hey, Jean, do you want to talk about this potential for congenital syphilis here? This is like a huge problem right now in the city.
Yes, it is. So I don't know, is already my maternal fetal medicine colleagues on the line? I thought I saw Jean Sheffield sent me a text. Oh, good. I'm going to let you talk about that because you really are the expert for that.
Sure. So you're talking about what aspect of congenital syphilis are you talking about?
Okay, so this is
Meaning what specific question?
This is getting relatively late, right? She's at 24 weeks. You don't really know how long. I mean, I don't know what her RPR was, but this is not a good situation. Let's just put it that way. And so she definitely needs to get treated. It'd be interesting. Do you know what her RPR was, Jean?
Oh gosh, this case was so old, I really don't remember because the point of it was just PrEP, but
Jean, you could just make up an RPR and say what you would do based on a made up RPR. That would be good.
There you go.
Yeah, no problem. So if they're showing up at 24 weeks and they have a diagnosis of syphilis, the maternal syphilis, the first thing we're going to do is we are going to do an ultrasound, preferably that day, looking for any evidence of congenital syphilis. The sole reason we do that is not that we're going to treat them any different other than we'll treat them on labor and delivery, because occasionally a baby that has ultrasound findings that are abnormal will have a interesting Jericho-Kramer reaction, up to and including potential stillbirth. But from a maternal standpoint, we will, if we have a diagnosis of syphilis in the mom, we will treat as long as you have given it enough time before delivery. It is impressive that even if a baby has congenital syphilis evidence on ultrasound, those ultrasound markers normalize with enough time. So the penicillin will treat the mom and cross the placenta and treat the baby. So we still have, at 24 weeks, we still have plenty of time to prevent it as long as somebody is aggressive about getting the mom treated.
So glad you were here, Jean. Thank you.
Yeah, it works out well. My whole life is syphilis right now.
I know, that's why I called you out.
No, Jean, I'm so happy you said that. I was just thinking about, I had a chance to hear more about ultrasound findings, and I thought it was really amazing how first hepatomegaly, potentially splenomegaly, all the way through to anemia. And if you have a very anemic baby, you can even look at the the MCAs and look at flow and see that there's differences. So I think the level of ultrasound findings now compared to a long time ago is just phenomenal. And I thought it was really interesting. And also the 30-day time period, which if it normalizes, they're no longer a case of congenital syphilis, which I just think is so interesting.
It is. We have, Parkland had a paper right as I got there as a fellow looking at the ultrasound abnormalities, including pubs looking for anemia and all that. And then we did a follow-up paper looking at resolution of findings. And it is amazing that they will respond. It takes a little while, but they will respond.
Yes, and just in case anybody, I'm sure Jean was probably going to say this, but I'll say it first. So Jean Sheffield is definitely a pioneer in this area and is one of the people that has really done a lot of great work looking at anti-treponemal antibody staining of placentas. So anyway, it's great you were on.
Yes, and we're so
It worked
fortunate
out
to have
well.
her on
Thank
our
you.
team.
And just very quickly, there's a question from Amanda in the chat about how you approach this sort of treatment in syphilis in pregnancy if there's a partner who is not available or amenable to testing and treatment.
Yeah, that's a tough one. So if we still, of course, will treat the mother, and then we will follow titers monthly. The vast majority of non-responsive or rising titers are in the settings of reinfection, of course. So in that case, the mom will probably end up being retreated at delivery because we can't just treat her every month, but we'll probably end up being retreated at delivery. And unfortunately, the baby will then have to go through, or the pediatric ID guys will usually recommend the baby going through an evaluation because the mother was re-exposed multiple times.
Thank you, Jean. That was great. So anything else on PrEP or syphilis or all those fun topics? Okay, I'm going to continue then, okay? All right. It's so hard to talk when you can't see people. So anyway, contraception in women with HIV, I think, safe and effective reproductive health and family planning services is an essential part of what we do for women, for individuals with childbearing potential. And just to let you know that now women with HIV can really use all contraceptive methods: pill, patch, ring, injection, implant, IUD, copper, or progesterone releasing. Tubal ligation is always an option, and vasectomy in the male partner. But just to consider, if you get particularly with the with hormonal methods, just to consider the potential drug-drug interactions with hormonal contraception when making those decisions. So I'm going to switch over to menopause. Our women are getting older. I feel like there's two groups now. There's this younger group coming up, and then there's this sort of older group that I've been seeing for a gazillion years. So overall, we're seeing an aging population. So just as, this is a tough time for women. Just remember, I just try to remind them this is a normal biological event, and it's, defined as 12 months of amenorrhea. And I just want to back up for a second, because a lot of our women, I don't know if the school system in Baltimore, but they really don't understand what menopause is. So it's really important that they understand that it's, it's the ovaries are winding down, and this is your body saying, no more pregnancies, that the lack of periods means that your ovaries are no longer functioning. And it's really not something they understand well. So I try to give, do a little education as well if they have a hard time understanding what menopause is. So the average duration of the perimenopausal period is about 4 years, although this is variable. And some of our women will tell us that they've had it for like 20 years and they may still have symptoms, particularly hot flashes and feeling warm. The average age for menopause is 50-51. There's been some discussion about whether or not women with HIV go through menopause early, but the literature is really mixed. And there are some studies that report, it's 2 to 3 years earlier versus the HIV negative cohorts. This is really difficult to interpret because of confounders. And some studies even report higher rates of early menopause with less than 45, or even premature menopause, which is defined as less than 40 years of age. I will just say quickly that I don't, in a woman who is of, menopausal age, who's coming in with menopausal symptoms, I don't do an evaluation because, I think it's just a waste of resources. However, if they're younger, or if they're less than 45 or less than 40, absolutely, I want to rule out any other reasons for their symptoms or their amenorrhea, including pregnancy, to make sure that there's not something going on with the thyroid or other issues. So, again, our women are often unprepared for menopause. I don't know if it's something that, particularly in the older age group, that's discussed in their lives by their mothers, or that maybe their moms are from a generation where they didn't talk about this stuff. But they'll often come with somatic, urogenital, and psychological symptoms that are related to this sort of perimenopausal period. And we do have a low use of menopause hormonal therapy. We now call it MHT rather than hormone replacement therapy. And I'm really, the thinking is starting to change a little bit about this, particularly women whose life is impacted by symptoms of menopause. And again, we have like these data gaps in regards to HIV and menopause. What is the impact of vaginal atrophy on HIV transmission and acquisition? Does menopause amplify the effects of HIV in the cardiovascular system, psychological and bone health? And again, is it safe, the safety and efficacy of menopausal hormonal therapy in our group?
And Jean, I just want to mention really quickly, there's a new ACTG study that I'm involved in that's just about to come online. It's going to be called the HOT study. It's going to look at hormone replacement in women living with HIV. Actually, I had to get it funded outside the ACTG because it wasn't considered within the scope of what the AIDS clinical trials group is interested in, but it is now funded. So hopefully will be a site for that because I
am thrilled to hear that. Yeah. So it's, our group is difficult because they have a lot of comorbidities, but there are certainly some women I think that could benefit from this and that don't have any contraindications. So thank you, Eileen. I'm glad you told us about that, and please keep us posted. So, menopause really the transition can be a quality of life issue, particularly with vasomotor symptoms. And I think there's commercials now on TV. Have you seen those commercials about VMH? So it's going to be the new hot word, I think, for patients coming in. The vaginal dryness, painful coitus. I always ask women when they're sexually active at this age, does it hurt when you have sex? Or you have any problems with sex? And they won't always, tell you that unless you ask them. And there are certainly things we can do for that, and, from using lubricants to, vaginal estrogen. As well. So mood swings, some of the SSRIs can be really helpful, both with hot flashes and mood swings during this time. And then abdominal bleeding is a big problem in older women. Irregular cycles, irregular bleeding between cycles, which we call IMB. You might see that in our chart notes sometimes. Menorrhagia, heavy bleeding, or menometrorrhagia, which is heavy bleeding throughout, just ongoing bleeding. So these are things that we all need to address, and these have to be evaluated. Abdominal bleeding has to be evaluated, particularly in older women, because we really need to rule out endometrial hyperplasia in that group. So, and then there's the long-term age-related comorbidities, cardiovascular disease, osteoporosis, and the metabolic syndromes that come with postmenopause and aging. So, I'm going to end there. There's lots I didn't talk about because we're out of time too. So I do want to introduce our staff. I introduced most of the staff, I think. I just want to give a shout out. I'm so glad that Jean Sheffield was on today, but her colleagues that work with us in the perinatal program include Lorraine Milio and Cynthia Argani, as well as Anna, who's my co-director for this program, Janelle, who you've all seen in the clinic, who is now the division director for gynecologic specialties, now that Dr. Anderson's gone, or actually she started before that. I talked to you a little bit about our newest member, Jennifer Lenore, Rose, Tasha, Dustin. We couldn't do any of this without them. And I wanted to introduce you to Sierra Richardson. She's our administrator for the program, and she can really help you, particularly with appointments. As a matter of fact, I got a chat today before this talk about could we see somebody I don't know if they were a clinic patient or from outside of the system, but we pretty much will see anybody you want. If she is the contact person for that, or Tasha. Tasha is, wonderful in getting people seen who need to be seen. So feel free to reach out to them. And then we have our fiscal folks as well. So I'm going to stop there, and thank you all so much for letting me talk today. And thank you for being such incredible colleagues in the work we do.
Thanks, Jean. I'll just summarize
I'm gonna,
for you that the chat is full of people saying thank you. And
oh,
I
you're
think that,
welcome.
and for all of the services you provide, I'll also just mention that, in a case that I presented previously in this conference with a domestic violence issue, Allison
Yeah.
Livingston and Rose Ramrup were like tremendously helpful. So also to
Yes.
know that your program is a repository for that knowledge as well. So I think there were a couple of things that came up in the chat that I think actually would bear another session where we talk specifically about this, like kind of on referral drop-offs that Laura Teaver was mentioning, and how we can close that gap. And then a couple of other things around care, specifically around women-related issues. So maybe we'll have a more informal discussion at some point in the future.
And we could put together a referral sort of list for you and send it as an email to everybody. Been kind of meaning to do that anyway. So thanks for reminding me about it.
Well, thank you so much for being here and for all of the services that all of you and provide for our patients. It's absolutely essential, and we're so grateful.
Thanks, Eileen. Everybody have a great weekend.
Have a wonderful weekend, everyone.